So when I think of how it can be necessary and the right choice to start somebody on buprenorphine who is currently opioid naive, I think of a patient that we had in our clinic who was with us actually for a number of years, and he did great. When he was with us, he was on a stable dose of buprenorphine and he was working. But at one point, his sibling passed away. His sibling actually died of an overdose, and this caused our patient to really sort of spiral out of control. And he really very much destabilized and stopped coming in and had recurrent substance use, and he was arrested and incarcerated. And so after a few months of being in jail, he got out and he came back to us. And he just really wanted to get back into care and get stable again. And this was somebody who wasn't currently using. They had no opioid dependence. He hadn't used in months. But we knew that the medicine worked really, really well for him, and he had very strong recovery before. So we talked it through. It made sense to restart him, and so we did. He got stabilized again. It was the right choice. He's back in treatment, and we were happy to have him.
The goals of treatment with buprenorphine include alleviating symptoms of opioid withdrawal and cravings, and the provision of opioid blockade. In addiction treatment programs, healthcare providers often encounter patients who are opioid dependent, meaning that without opioids in their bodies, the patients do not feel normal and may experience painful and uncomfortable withdrawal syndrome. When these patients are treated with buprenorphine, the medication occupies opioid receptor sites, allowing the patient to feel and function normally. What happens when a person has a history of moderate to severe opioid use disorder, but is not currently using or physically dependent on opioids?